a general introduction. And get us started. Welcome, and tonight we have Dr. James Posey III, who is the NABONC president, and he is also a medical oncologist, director of the gastrointestinal program of medical oncology at the Sidney Kimmel Cancer Center. He's also co-director of Jefferson's Pancreatic, Biliary, and Related Cancers Center at Sidney Kimmel. Tonight, we will hear from Dr. Posey, who will share why NABONC, the significance, the importance, and why it is relevant today. Dr. Posey.
Thank you for that kind introduction. And it's certainly a pleasure to have an opportunity to talk about why NABONC. And so let me see if I can share my screen. So I think most of us in cancer care, in any aspect of cancer care, recognize that there are disparities that continue to exist in outcomes and as well as incidence. And so NABONC, which is short for the National Association of Black Oncologists, we believe that we have a multifaceted approach to improving cancer care outcomes for Black patients. So again, the goal, I'm going to share briefly a few slides, and then if we have an opportunity to have some exchange with those that join, we'd love to do that. But in brief, addressing a disparate outcome we recognize is complex. We didn't get to this place in the 21st century, if you will, as a consequence of one problem. I think that would have been eradicated, resolved, and we would not be talking about differences in outcome as well as differences in incident, but it is multifactorial. So we know that the approach to addressing the issue needs to be multifactorial. With the National Association of Black Oncologists, we think about three principal areas where we need to make a difference. One is with access, the other advocacy, and thirdly, the appropriateness of the interventions or cares that are being provided to patients. Of major note is the fact that there are components of access that are patient-specific and family member-specific, and then there are components that are certainly beholden to the healthcare provider. I listed here training and education, but it goes a little bit further than that. And I just want to highlight one thing, and when we come to the end of the slides, as it pertains to education. So when it pertains to advocacy, we think about speaking loudly, but really the question, or one of the questions is, who's on my side? Who's with me, and who's helping to provide reinforcement from a patient side? And then in the healthcare industry, we certainly understand that we have to become advocates for those that we're providing care for. Appropriateness, ensuring equitable and appropriate cancer care. And sometimes that goes beyond looking at the diagnostic code. You have to look at the whole person. So addressing disparate outcomes in cancer care, as I mentioned, there are many factors that contribute to the disparity, including lack of access, quality care, inadequate education and training for healthcare providers that are delivering the care. And at NABONC, we really hope to dedicate time, effort, as we grow as an organization to address each of these areas head on, with the goal of creating effective, long-lasting change. Because we're not here necessarily for a grant-funded opportunity for 2 years or 5 years. but we are here to stay. So I mentioned these three pillars that are important to us: access, advocacy, and appropriateness. And access involves breaking down barriers. And breaking down barriers is not simply having access to the doors of a high-quality cancer center, although for some that could be a limitation. Access is really assuring that a patient understands on their end why they're accessing a particular facility. And so in some cases that requires, patient engagement in and access. Other times we do need to provide additional support. So access alone involves addressing issues related to things such as clinical trials, as I have here at the bottom of the slide, treatment options, and in some cases, maybe modifying the treatment to make it more appropriate for a patient who may have comorbid illness. The patient component involves proper education. I'll take a moment to insert something here, and that is, education is not simply just telling a patient what the guidelines would say is the appropriate recommended therapy. Education is more often involves listening to the patient and hearing what they convey to us about a problem. And in some cases, the problem that they convey tells us what may be precluding them from understanding what it is we think is appropriate. I think most healthcare providers, when it comes to cancer care, take a diagnosis, this is the treatment. So this is the problem, this is the treatment. The complexity, of course, is making sure that the patient can properly engage around what it is we're talking about. And that's really, truly access, that the patient has heard what we're saying and that they can put their hands around it a little bit. And it's not infrequently that patients will convey that they're not in healthcare and that they've never had a problem like this before, and which is understandable because no one typically votes to get this. So one key to enhancing access is hearing what a patient is telling us so that we know how to convey information appropriately. So breaking down these barriers, I just want to focus on this highlighted point here. The reason we wanted to build a network of like oncologists and other passionate healthcare providers is so when we emphasize something, there's an exponential power that comes along with the voice of a body of oncologists that can come together and reflect on, as well as identify barriers to access. And the body of our collective gathering, if you will, has exponential power. And this, I believe, can move a needle. Many of us are at different institutions, and we may be champions within our institution, and we may represent a small microcosm of those that are championing the cause of disparity. But collectively, as an organization, we easily represent a tenfold increase, and in some cases, maybe more of an increase of the rationale for addressing some of the issues that we know persist across our institutions and centers of care delivery. So on the healthcare provider side of access, training and education, I talked a little bit about this, that there has to be a bit of sensitivity, and this training may include specific training in areas of cultural competency and understanding some cultural norms that may not allow a patient to hear us and to understand what it is we're trying to convey to the patient. We have likely learned about implicit biases that we may harbor. All of us harbor implicit biases in areas, and some of those areas are in areas where we may not be as culturally sensitive as we think, simply because we may know the common treatment paradigms for a particular disease process. And then our communication skills. Touched on that as well a little bit by saying that one of the things we want to focus on as providers is making sure that we're adequately listening to our patients. What is the first thing that the patient says when we come into a room? Do they, after, hopefully there's some level of greeting, but after that, what are they communicating to us? Is it, doctor, I really want to know what stage cancer I have, or is it my feet hurt, or is it I'm hoping we can get this done in 20 minutes because I got to put money in the meter and I can't be late to pick up my wife? All of these things communicate something about where this patient's state of mind is relevant to a cancer diagnosis and should be factored into how we move forward. Advocacy, the graphic here is it doesn't necessarily involve shouting and screaming and being angry. Advocacy, I think more than anything else, if I could tie another word to it, is diligence around the aspects of the care conundrum. So typically, when a patient comes in for the first time, it's generally not one thing that they're biting off. It's multiple things. Having a patient advocate or a patient having an advocate with them that can help help the patient consolidate. Some cases help console the patient along with the healthcare provider and the team is important. And one of the things we want to do in future talks is focus on all of these areas: access, advocacy, and appropriateness. So as we begin to build, if you will, a body of material that can become guidelines. So essentially, we don't want the patient to become lost because they came by themselves. They may not have caught all the information, and maybe even inadvertently they've been marginalized and in their healthcare, and they're already set back, if you will, as a consequence. So appropriateness, and I've highlighted a few things here. Clearly, we want to think about what's the most appropriate intervention for diagnosis. Sometimes that's diagnosis, sometimes that's stage of diagnosis. Usually both are relevant. And in other cases, it's what other healthcare professionals are going to be engaged and involved in their care. One aspect of professional advocacy is us lobbying in some cases for our patients. So for instance, patient may see me as a medical oncologist, and I may have to lobby a little bit more aggressively with the surgeon or radiation oncologist or an interventionalist around the dynamic of a patient's care. Oftentimes, someone not caring for the patient is reading the chart, and it's in some cases quite easy to make a decision not to engage because of what one has read in the chart. And often that requires the healthcare provider engaging with another healthcare provider to really, if you will, become the patient's advocate, go to bat for the patient. Oftentimes things may not be straightforward. So that gets to the other highlighted point there, the unique needs that are identified in the patient that we as a healthcare provider understand may require some breaking down of barriers perhaps among our other healthcare providers. And then I think all of us want to engage in best practice. And one of the things we want to think about from a NABONC perspective is how often does best practice change, if you will, when we think about some of the patient dynamics that our patients bring to the table in terms of comorbid disease, changes in organ function, and should that limit how we dose patients, the schedule of administration, things of that nature. These are things that we want to have future discussions about as we think about appropriateness. And that might be my last slide. I did want to also, I'm sorry, I left this out on the bottom of the slide here, that we do need to think about unique ways to identify funding sources to answer some unique questions that go unanswered because they aren't really typically captured in, if you will, a randomized controlled trial where the patients are largely not of Black and African American descent. And the question is should we have funding to carry out research specifically in those patients, or at least to make sure that the trials that are going forward have arms that include patients that are Black and African American. So support for research and innovation in this area. And these are things that I think as healthcare providers with exponential voice can begin to echo. And I believe that industry partners, our academic institutions and others would hear the cry collectively with the exponential power that we would have together to begin to make some of these adjustments. And these are just a few reasons why NABONC. We need you. We need your experience. We need your passion. And collectively, we believe that we can move the needle in some very pivotal areas. So moments of your time, but bargaining and leveraging the collective experience that I think we would find as we gather from time to time, as we gather a lot of commonality in our stories. And we just need to engage appropriately to put the approaches, effective approaches, into play. And I'll stop with that.
Thank you, Dr. Posey, for that very informative and motivating introduction to NABONC and really making it relevant and important. I do have a question for those who want to know how to become involved. What is the best way for them to become engaged with the organization?
Well, I would say the best way, the easiest way for you to become a part of NABONC is to go to our website and click on the little brown button that says join. Put in your information, and there may be an area of interest. I did not talk about areas of interest, but we think about three. It may be that you want to work in a community advocacy area. It may be that you're at an academic institution and you're interested in the research. And it may be that you're interested in education. But essentially, click a button on the webpage, join. Membership is free. We hope to have meetings like this and other meetings, but that's just the easiest way to join. And please let us know if you would, you're an area of interest. And if you're interested in everything, that's fine too.
That sounds good. I did hear, when you talk about advocacy, are there organizations currently that NABONC is associating with, or is it general? Are you reaching out to make those partnerships with certain advocacy organizations? What does that look like for NABONC in supporting the community?
Sure. Well, very early on, we have made some initial contact with other organizations, typically foundations that are focused in particular diseases. We've had some early conversations, really just to understand what some of the advocacy groups are doing. I think as we grow, we would perhaps find opportunity in areas of common ground where we can leverage some of the advocacy groups like Prostate Cancer Foundation and others to identify specific areas. Typically, advocacy groups are in some ways more focused around a disease state. But again, this is early, and so I don't want to lock all of the advocacy groups into disease states, but the ones that we've at least connected with and had conversations were disease state focused, with a recognition that there is disparate outcomes. And so that's a component of what they do. Whereas for us, our sole focus is to address the disparity.
Perfect. Thank you. I don't have any additional questions at this time. This has been, like I said, very informative, helpful. I hope that there will be others that seek to join and reach out to other colleagues to bring us together, bring the group together more.
No, I certainly agree. I think it's settings like this where we establish some key principles. I think it'd be very quick that we all identify some common ground, and then we figure out approaches to common problems. If I can give you an example of this real quickly, one of the things that affects moving forward, as I alluded to, is cancer memes. So memes are those things that we, just to put a definition on it, because there's two. There's the old definition, and then there's the internet definition. So I'm thinking more about the old definition, and that is a widely held belief that's not based in scientific validation, or it's not been scientifically validated. Now, personally, I'll be the first one to say that not everything that I do has to be scientifically validated. But of course, when it comes to healthcare, it does kind of make a bit of a difference. And one of the things that I've thought about is even a brief session where we talked about some of the common cancer memes that patients bring to the table. One of them being, well, doc, I don't really want to undergo an operation because if air hits my tumor, it might spread. And you've heard that, I'm sure many of us probably have, but there are other memes. And so one of the challenges that we have is, and things that we can build from our collective experience, is even on our website, we will consider, from a patient usage standpoint, having patients be able to access a series of scientists and others speaking to some of the cancer memes that are very common in our communities, and make it difficult to have this discussions around care, because a patient they heard what you're saying, but they're also sort of counterbalancing that by the memes that they have existed by for many years. So breaking down some of the cancer memes is one thing that I think we can, develop, whether it's, I wouldn't call it guidelines, but just kind of a white paper or information that we would put on the website.
Sounds like an opportunity for clarifying misinformation, disinformation in a space of trust for patients, which I'm hearing NABONC will provide with the 3 pillars that you've described. So very excited and very exciting information as well. So thank you for your time today.
You're welcome.
Okay.
So I do want to highlight something you said real quickly, and it ties into what I just said previously. A lot of times the mistrust is not because the healthcare provider told a patient something wrong. It's that it wasn't interpreted properly because of a cancer meme. So,
right.
Consequence, there's mistrust, and there was a lack of connection because we didn't dispel the cancer memes, and we didn't dispel the other widely held beliefs, or I saw what my parents went through when they had, or when my grandfather had a cancer, and I just couldn't bear to do or go through what I saw he or she go through. And so those are the kinds of things that areas where mistrust can be handled in a different way. And that's what we hope and endeavor to do.
That's great. Thanks for that point of clarification too. And I'm going to remember the meme. Okay.
Yeah.
All righty.
There are many others, but we want to maybe compile them, and we may even learn more from some of our patient advocates, in fact. So yeah, it'd be helpful.
That sounds great. Thank you so much for your time today.
Thank you.
Okay.
Been a
Thank
pleasure.
you.
All right.